In this session, we will discuss the basic understanding of asthma. We know asthma is a common condition and causes significant workload for GPs and hospitals. But did you know that every 10 seconds someone in the UK is having a potentially life-threatening asthma attack, and that every day 3 people die with this condition in the UK? Most of these are preventable with good management of this condition. The prevalence or the number of people with asthma is increasing, especially in children and young adults, where we know that this condition can cause up to 15% of this age group to be affected. We also know that asthma is more common in the United Kingdom, New Zealand and Australia, but is less common in countries such as Africa, Malaysia and China. What we are aware of is as these countries become westernized, the prevalence or the number of cases of asthma tend to go up. Worldwide, 300 million people are affected by this condition, and we know that this number is to increase to 400 million by 2025. This session will provide a basic understanding of what asthma is and the way you can manage the condition. Other video clips will provide more in-depth information on different aspects of this condition. I hope you learned something new about asthma in this series, so let's move on to series 1. Let's talk about the basics and start from the beginning with asthma. So where does asthma occur? If we look at our lungs, the actual breathing starts with the mouth, which is here at the top. This then goes into your throat, and further down, just behind your Adam's apple, what you have is the tube then breaks into 2 parts. The first bit you have here is your food gullet, otherwise known as the esophagus. And the second tube that comes off is your windpipe, otherwise known as your trachea. Now, the trachea then goes further down and breaks up into a number of different sections, starting with the bronchi, and these bronchi then break up into further tubes, which are called the bronchioles. And these bronchioles will then go into small sacs further down into the lungs, which are the alveoli. Now, air would go naturally through the mouth or the nose, down the tube at the back, the larynx, and into the windpipe, the trachea, into the bronchi, into the bronchioles, and into the alveoli, where blood from the heart comes along, which requires oxygen, collects the oxygen here at the alveoli, and then goes through back to the heart, where it's pumped to the rest of the body. And that oxygen, once used up by the body, will come back to the heart, and the heart will then pump it back to the alveoli, collecting more oxygen. So this is how the lungs and the hearts work together. Now, the problem with asthma is at this level, at the bronchioli level. We have the lumen, and as mentioned previously, we have the smooth muscle cells around the edges. Now, in asthma, what happens is that the smooth muscle around the edges of the hole, or the lumen, is triggered, causing the actual hole to get smaller. And we'll have a look at what happens in a few minutes. But essentially, once this happens, the amount of air that can get in through the hole gets less and less, leading eventually to what is an asthma attack. Now, looking at the actual muscles here around the lumen, if we draw this like so, there are a number of areas in there, what are called receptors, which turn the muscle on and off. Now, one of the receptors is what we call a beta receptor. And although this might sound a bit complicated at the moment, this will all fall into place once we look at the medication later on. And the other type of receptor there is called a muscarinic receptor. Now, the beta receptor is the one that helps to open the tube, whereas the muscarinic one will close the tube. Now, this is important when we look at different forms of treatment for asthma. The medication we tend to initially use are the blue inhaler, the Ventolin, the salbutamol, the Bricanyl. Those type of medications are what we tend to call beta agonists. Now, an agonist is something that works with something in a positive way. So a beta agonist will work on a beta receptor here, and by activating that receptor, what it will do is open that tube out. Now, if you have something that's a muscarinic agonist, that would close the tube, which is not what we want. So another treatment that is used later on in asthma management is called an anti-muscarinic. Now, anti would mean against or negative, and therefore anything that works against the muscarinic receptor will do the opposite of what that receptor does, which is it will open it. So a beta agonist opens the airway, and an anti-muscarinic will also do the same job by opening the airway. Now, the third element here, which we've not talked about, which causes significant problems, is inflammation. Now, inflammation is a big problem with asthma. It's actually the inflammation that causes the difficulty with the airway opening up and the muscle fibers working effectively. And if managed inadequately, long term, the inflammation will cause permanent damage to the airways, which will then cause the medication not to work as effectively. That then becomes irreversible. And another condition we'll look at later on in one of the other video clips is COPD, chronic bronchitis, emphysema, number of names. And again, that is a condition where medication isn't as effective as it is in asthma, because the condition is predominantly irreversible because the airways don't open up as effectively. So let's just recap on what we have up to now. The beta receptors, and what we're going to use is an agonist, and as I said, that's usually your blue inhaler. Secondly, we have a problem with inflammation in the airways, which needs treating, and for that we tend to use the inhaled corticosteroids, or you'll know it as a brown inhaler, orange inhaler. Comes in a number of forms. In bad cases of asthma, we would tend to use oral prednisolone, which again is a steroid. And thirdly, in terms of treating the second type of receptor we talked about, you have the anti-muscarinic drugs, which again open the airways. So here now we have 3 different forms of treatment, all of which can cause an opening in the airways, helping the relief of symptoms related to asthma. Now, with asthma, there are various classification systems that they use, but one of the common ones is to define whether the asthma is intrinsic or extrinsic. Now, when looking at possible causes of asthma, we're looking at things that could stimuli from outside the body that enters the airways, causing the smooth muscle and the tubes to become narrow. So what kind of things can cause this? We know that cold air and exercise are 2 things that can cause the airways to narrow. Very likely this is down to the air coming down into the bronchioles, and it's dry air, it's cold air, it's not had enough time to warm itself up, which causes an adverse or a negative reaction on the tubes, causing the tubes to narrow down. With exercise, this tends to occur more after exercise than during the exercise, but again, depending on the severity of asthma, it could occur at any time. Other things that could cause problems with the airways is atmospheric, so things from around you in the air, and these are things like tobacco, smoke, car exhaust fumes, strong perfumes, or even if in the air at certain times of the year if there's a large concentration of dust in the atmosphere. So these are kind of things that can set things off. Now, what about other things? What about diet? In terms of diet, we know that things like fresh fruit and vegetables tend to be more protective against asthma, and this may be down to an antioxidant effect that the food has. But we do know that there are a class of drugs called NSAIDs, or non-steroidal anti-inflammatory drugs, of which there is aspirin and other non-steroidals such as ibuprofen, otherwise brand names such as Nurofen, which can cause problems with asthma. So you do need to be aware. It doesn't happen very often, but there is 5% of the population with asthma who are sensitive to these kind of drugs, and they do need to be aware of whether these drugs can cause a negative effect and whether they need to avoid them in the future. Another class of drug which can be a problem, which is commonly used, are what we call beta blockers, generally prescribed by your doctor. An example of beta blocker is propranolol, and these drugs tend to be used for things like angina, if you have a heart problem, angina, or if you have high blood pressure, otherwise known as hypertension. So again, you need to be aware of whether you have asthma, and if you do, then you need to make sure that anybody prescribing medication isn't giving you beta blockers, which may make your asthma worse, even though they are trying to treat your asthma. When looking at extrinsic factors, there are other possible causes such as house dust mite, furry pets such as cats, fungal spores. So there are other things that we need to be aware of when looking at possible causes of asthma. There are a couple of conditions which can be associated with asthma. These are generally what we'd call atopic conditions. And these are things like rhinitis, when you get a persistent runny nose. There are others such as eczema or atopic dermatitis and hay fever. So it's not uncommon when you suffer with one of these conditions for you to also develop symptoms of asthma, and that's something that you should be aware of. And again, there could be a family history of any of these conditions, which increases the possibility of the children developing any one of these conditions. In terms of the genetics of asthma, it's not quite clear what causes or what the mode of transmission is, but what we do know is that it's not a single gene that causes the asthma. In fact, it's likely it's a number of different genes. So here we have a number of causes for extrinsic causes for asthma. What we have, as we drew before, is that you have your mouth, and then essentially it comes down into your throat, and from the throat it then comes off into two tubes, and we said that this was the windpipe or the trachea. Now, in terms of the other bits of the body that are around in the vicinity of the trachea, we know that this second tube, or this first tube that we described, is the esophagus, and the esophagus, or your food gullet, goes down, and beneath your diaphragm it turns into the stomach. And here we have the stomach. Now, occasionally what happens is some of the contents from here will come up the tube and then drop downwards towards the windpipe. Now, this is something called GORD, otherwise known as gastroesophageal reflux disease. In other words, there's matter or content, some of the content from the stomach, that's actually refluxing up and then dropping down into the windpipe, causing irritation and symptoms of persistent coughing, which may mimic asthma symptoms. The other one that does happen is above the nose, above the mouth where you have your nose, you have rhinitis, and that then falls down also through the throat into the windpipe, causing cough, and that is post-nasal drip. So we have three conditions here. When a patient presents with a cough, could it be a post-nasal drip, where they've got catarrh dripping down the back of the nose into the into the throat, causing a cough? Could it be gastroesophageal reflux disease, where matter is coming up and irritating the cough reflex? Or could it be asthma? And all three conditions need to be considered, as the treatment for all these will be different. Managing GORD with inhalers is not going to be effective, and neither is managing post-nasal drip with your blue inhaler going to have much of an effect. After watching this clip, I hope you now have a basic understanding of asthma. To build on your knowledge and give you more control, let's move on to the second session on asthma diagnosis.